In this diagram, let us briefly review the coronary blood supply to the heart. This is the left main trunk arising directly from the aorta, which divides into two bigger branches, major branches, the LAD and the LCX. This LAD gives different small branches and left anterior descending artery or LAD and descending artery, the distal part of the descending artery and the diagonal branches. The LCX or left coronary artery binds around the heart and supplies the posterior part and also the lateral part of the heart. LAD supplies the anterior and lateral and septal part of the heart. This is the small septal branch from the LAD. So this is the left main, LCX and LAD. Then here we see the right coronary artery. This also arises directly from the aorta, nodes for the sinus node, and then the right coronary artery traverses in the groove between the atrium and the ventricle and gives off right ventricular branches, anterior marginal branches and post-diagonal branches and winds around and meets with the left circumflex artery. This supplies the inferior and posterior part of the heart. So to say, there are two coronary arteries, right and left. The left one again divides into two, LAD and LCX. That means there is a three-phase blood supply to the heart. Remember, all these blood vessels are interconnected and there is lot of collateral circulation between one channel and the other. So much so, if one channel is compromised and narrowed, the blood flows in the reverse direction and fills the coronaries. That is how majority of us we survive in spite of there being such significant blocks in some of these arteries. The heart can be viewed to be having four different surfaces. The anterior surface is covered by left anterior descending artery and left circumflex artery. Left lateral surface is covered by left circumflex artery and partly by the LAD. Inferior surface of the heart by right coronary artery and LAD terminal branches. Posterior surface of the heart is covered by RCA and LCX branches, and right and left coronary arteries arise from the aorta. They are 2.5 millimeters at the origin, 0.5 millimeters at the end. Coronary arteries, remember, fill during diastole. During systole, the aortic cusps come in the way and then block the coronary ostia, and no filling occurs during systole. Only during the diastole, the coronaries fill. That is why the diastolic pressure is very important for coronary filling. Epicardium to endocardium, the blood supply goes. From the blood supply is from epicardium to the endocardium. The farthest part of the heart to the blood supply is the endocardium, and that is the one which suffers most. So even though the endocardium is closest to the blood, there is poverty amidst plenty. These are famous drawings by Nutter. Nutter's medical drawings are internationally renowned. So here we can see the infarcted area. This is an anterior infarct in the anterior, and this is a sort of lateral infarct, lateral wall of the heart, an inferior infarct and the posterior infarct when we look at the heart from behind. So which leads, which artery is affected in which part of the infarct and which are the leads which show is summarized. That is the MI, the blood supply, and the leads which depict these changes in the ECG are summarized in this one diagram. So anterior infarcts, LAD is the culprit vessel and it is seen in V1 to V2, V3 and V4. Septal usually V2 and V1, septal and anterior V1, V2, V3, V4. Lateral part of the heart is supplied by LAD and partly by LCX, seen in V5 and V6 leads, L1 lead and also in AVL. Whereas in the inferior part of the heart is supplied by the RCA and inferior infarct is seen in the inferior leads which are L2, L3 and AVF. The posterior part of the heart is supplied by RCA and partly by the LCX, and here we see mirror changes in V1 and V2 because we do not have direct leads which can give us information about the posterior wall, but V1 and V2 are exactly opposite to the posterior wall, so much so they give mirror changes of ECG whenever there is a posterior infarct. Remember, these are not watertight compartments. Patient will have anterior as well as lateral, anterior as well as inferior, inferior and posterior, lateral and inferior, all sorts of combinations can occur. Then the changes will be seen in the corresponding leads as we can see in this table. So this is a tabular way of looking at which leads will be affected and which infarct. Anterior diagonal branch of the LAD is the one. Anterior leads are V3 and V4, the blue color. Septal leads, septal branch of the LAD, V1 and V2, the yellow color. Lateral leads, mainly the LCX, lateral leads are L1, AVL and V5 and V6, the red color. Inferior part of the heart, posterior diagonal artery from the RCA, and these are in the violet color, the posterior leads, lead 2, lead 3 and AVF. This is another way of just representing the same information which we have given in the previous slide. Now, just as we have the TIMI disc score of 7 points in NSTMI, we have got the TIMI disc score for STMI also. Age is an important criterion. Anyone less than 65 to 74 years, 2 points are given. Less than 65, 0 points. More than 75 years, 3 points. Diabetes, hypertension or history of angina, persistent angina, 1 point each. Systolic blood pressure less than 100, 3 points. Heart rate more than 100, 2 points. Killip class 2 to class 4, that is the severity of the heart failure, class 2 to class 4, then 2 points. Killip class 1, no points. Anterior STEMI or left bundle branch block. If it is an anterior wall infarct, the prognosis is going to be bad, or if there is a left bundle branch block, again the prognosis is not going to be good, and that's why we give 1 point for that. Time to reperfusion. The patient had a pain, and when he came to us for reperfusion, the time between the onset of pain and reperfusion, if it exceeds 4 hours, then give 1 point. Anything less than 4 hours, 0 point. If the weight is less than 67, again give 1 point. So all these points are added to work out a TIMI disc score. How that is interpreted, we will see the subsequent slides. Okay, are there any other conditions which can produce ST segment elevation in the ECG? Is it that ST segment elevation is such an important thing that we can say that in 100% of the people who have ST elevation, it is going to be myocardial infarction? No, ST elevation occurs in various other conditions too. If he has got prior myocardial infarction which has healed and there is an aneurysm formation, even though there is no acute coronary syndrome, the ST segments will be elevated in those leads. Aortic dissection involving the coronaries can produce ST segment elevation. Pericarditis and myocarditis due to viral, bacterial or chemical or any type of pericarditis for that matter can produce ST elevation. LVH, gross LVH or aortic stenosis, severe aortic stenosis with LV strain can also throw a minimal ST segment elevation. Hypertrophic obstructive cardiomyopathy, Brugada syndrome, a familial disease wherein the ST segments are elevated due to repolarization abnormalities of the myocardium there and not due to ischemia. Coronary vasospasm, it's called vasospastic angina. The ST segments are elevated very transiently. Once the vasospasm is relieved, ST segment returns to baseline, and this is an angina and not an acute coronary syndrome. Early repolarization. Sometimes some patients do have a normal variant of early repolarization changes, so much so the repolarization starts very early before the R wave comes and touches the baseline, so it appears as though that the ST segment is elevated. Pulmonary embolism is another common cause of ST elevation. Hyperkalemia produces peak T waves. Along with peak T waves, the ST segment also is pulled up. So these are some of the conditions which we need to keep in mind when we see a patient with ST segment elevation who does not fit into the diagnosis of acute coronary syndrome manifesting as ST segment elevation myocardial infarction. So these are important things that we need to understand and rule out those conditions before we say with certainty, okay, this patient has got ST segment elevation myocardial infarction. When we have a patient of ST segment elevation MI, there are certain important informations we need to gather from the history and physical, from the labs and from the previous records of the patient. From the history and physical, what are important? The exact time of onset of chest pain. Why this is important? Because this is the one which determines whether the patient will go for PCI, whether the patient will go for thrombolysis, whether he will get benefited by thrombolysis or not. If the duration is more than 12 hours, thrombolysis is not going to be useful. If the duration is more than 90 minutes, PCI may not be that successful. PCI should be done ideally within 90 minutes. And then thrombolysis should start within 30 minutes. DDF ST segment elevation, which we have seen in the previous slide, must be kept in mind whenever we look at patients with infarction. Contraindications for PCI and fibrinolysis should be evaluated while we are evaluating the patient. Are there any contraindications for PCI? Are there any contraindications for lytic therapy? Because once we choose the therapy, we need to make a decision whether the patient is suitable or unsuitable. Signs of congestive heart failure, signs of autonomic dysfunction, complications of myocardial infarction, all have to be looked into, because these have an implication on the prognosis of the patient. Then of course the lab values, look at the CBC values. Anemia is a great contributor for myocardial dysoxygenation, and then of course blood biochemistry, basically about the renal function, about the hepatic function, and of course these are also important as far as anticoagulation is concerned. Partial thromboplastin time, prothrombin time, international normalized ratio. These give us an indication what is the baseline coagulation status of the patient, and when we start anticoagulation, we will be able to compare with those results. Of course, needless to say, cardiac biomarkers are highly essential, though they are not contributing to the diagnosis of myocardial infarction, ST segment elevation myocardial infarction, because once there is ST segment MI, we know that it is already cardiac biomarkers will be elevated. Why we do cardiac biomarkers? It is to stratify, risk stratify the patients. Patients who have got high elevations of enzymes, they do badly compared to those with a little bit less elevation of these biomarkers, particularly cardiac troponin. So when you want to look at the patient records, what are the things which you would like to see? Most importantly, look at previous patients' ECGs. Is there any bundle branch block in the previous ECGs? If so, the present bundle branch block is not new onset. Like that, are there any changes of infarction or IHD or acute coronary syndromes in the previous ECGs? What are the last cath reports like? What is the previous CABG report like if the patient underwent already CABG? Prior echo reports also will throw a light on what was the cardiac function, and we can compare that with the present function. The other important biomarker that we need to look in all patients of ACS is BNP. BNP is B natriuretic peptide. Pro-BNP or anti-pro-BNP is usually done. If you see patients with myocardial infarction with ST segment elevation, you can see the patients with the red area, that is less than 43.6 picograms per ml, are very few, whereas those between 43.7 to 81.2 are blue bars. Then the next higher value is green bars, next higher values are the yellow bars. When you see myocardial infarction without ST segment elevation, you see the maximum elevation in them. In those with ST segment elevation myocardial infarction, we don't see that much increase in the BNP versus in case of unstable angina also they are elevated. So it's important to know the BNP values also, because when we use the triple markers, the triple marker means troponin, the BNP and the C-reactive protein. In risk stratifying, we need the values of BNP. Just now I mentioned about the triple markers in ACS. What are these triple markers? TROP-I, CRP, HSCRP of course, and then the BNP, B natriuretic peptide. If we do the three markers, number of patients with no elevation of one of the markers, 30-day mortality risk is very low. One of the markers is elevated, 2.1%. If two of these markers are elevated, 5.7% 30-day mortality. If all the three are elevated, 13% of them, and the 30-day mortality risk. So this is as per the TIMI 18 study, tactic study, which has very clearly proved that looking at these three enzymes can prognosticate the mortality of a patient.